Good morning. My name is Joseph Ricotta. I'm the National Medical Director of Vascular Surgery and Endovascular Therapy for Tenet Healthcare and the Chairman of the Department of Vascular Surgery at Delray Medical Center. Today is my pleasure to present to you TCAR, a talk on TCAR, transcarotid artery revascularization, which is a new treatment alternative for patients with carotid artery disease and to prevent stroke. Carotid artery disease is the most common cause of stroke, and usually it is when you have plaque built up in your carotid artery and fragments of the plaque can break off and go into the brain and cause a stroke, or it could impede blood flow into your brain, which can often cause a stroke as well. Up to 1/3 of strokes are due to the carotid artery. So plaque in the carotid artery causes about 30%, 33% of strokes. And if anybody has ever known or taken care of a patient that has had a stroke, it is a debilitating thing often and often a fate worse than death. The challenge of stroke prevention is that most patients with carotid disease are silent. They don't present with any symptoms until it's too late and they actually have a stroke. So the first symptom is often a stroke in and of itself. And so how do we identify these patients that are asymptomatic, that are at a risk for stroke, and prevent that stroke from happening? Stroke is the third most common cause of death in the United States. There's over 1 million cases annually. It's a $50 billion cost to the U.S. healthcare system in 2019, and there is a death from stroke every 3 minutes in the United States. It's estimated that for every one symptomatic stroke, there are 14 silent strokes that occur that can alter patients' cognitive function. Risk factors for carotid stenosis and stroke are advanced age, usually over the age of 65 to 75, smoking, hypertension, high blood pressure, high cholesterol, diabetes, metabolic syndrome, and obesity. So the first stage in stroke prevention is to modify those risk factors. So patients that smoke, we have to get them to stop smoking. Obesity, exercise, weight loss, manage the patient's blood pressure, manage the patient's cholesterol levels, manage the patient's blood sugar if they have diabetes. Every patient should be put on what we call best medical therapy for carotid disease, and that's usually a statin, which not only normalizes patient's cholesterol level, but also is a plaque stabilizer. So it prevents plaque in the carotid artery from breaking off and going up into the brain. So even if your cholesterol level is normal, we want to put you on a statin because of the plaque stabilizing effects. Blood pressure medicines, diabetes medicines if you have diabetes. Now, which patients should be screened for carotid stenosis? The American Heart Association has put out some guidelines for this. Any patient that has had a prior stroke or what we call a TIA, a mini stroke, any neurologic event should be screened for carotid blockage. If they have what's called a carotid bruit, which is when we listen to the neck with a stethoscope, and if we hear an abnormal swishing sound, that means that there might be some blockage and turbulent flow in the carotid artery. Those patients should have a screening test, usually with a duplex ultrasound, an ultrasound of the carotid artery, which is a non-invasive test that we can do very simply in the office in about 20 minutes. Any patients that have vascular disease elsewhere, if they have coronary artery disease in their heart, if they have peripheral artery disease in their legs, if they have aortic aneurysms, those patients are more likely to have carotid disease as well, so they should be investigated with a carotid ultrasound. Or if you have 2 or more of the risk factors that I discussed, so if you're a smoker, if you have high blood pressure, if you have high cholesterol, if you have diabetes, if you have a family history of smoking, if you have 2 or more of those risk factors, you should have a carotid ultrasound to make sure that you don't have blockage in your carotid artery or what we call carotid stenosis. If you are identified as having carotid stenosis, what are the options for treatment? So there's 3 main categories of treatment. One is medical therapy, what we call best medical therapy. Every patient, no matter what their degree of stenosis, should be on best medical therapy, as I've already alluded to, and that is antiplatelet medication with aspirin and or Plavix, statins, not only to lower your cholesterol level, but also as a plaque stabilizing effect on the plaque. Blood pressure medications if you have high blood pressure, smoking cessation, exercise, weight loss. So everybody gets medical therapy no matter what. Now, if the disease is severe enough that it needs to be treated, and usually that is patients that don't have any symptoms, if your blockage is 70% or more, it needs to be fixed. Or if you have symptoms, if you've had a stroke or a TAA or a mini stroke, 50% is the cutoff. So if your blockage is 50% or more, then you should have it treated, because the studies have shown that if you're above those thresholds, your risk of having another event or a stroke is much less with surgical treatment than if we just leave you on medical treatment and just medicines. There's two ways to fix the carotid blockage from a surgical standpoint. One is a carotid endarterectomy, where we make an incision in the neck and we go into the carotid artery and we open it up and we scoop out, clean out the plaque, and then we close it up again with a little patch. Usually stay overnight one night in the hospital and go home the next day. And the other way is with a stent, where we go inside from the inside with wires and catheters, and instead of cleaning out the plaque, we balloon it open and then lay a stent inside to keep it, the channel in the carotid artery open. And those stents could be put in either through the groin, what we call transfemorally, through the femoral artery, or with this new procedure called TCAR, which we're going to go into in detail in a minute. This is a slide just on best medical therapy. We've sort of gone over that already. Every patient should have best medical therapy, as I mentioned. But even with best medical therapy, this slide is very telling that the progression of asymptomatic carotid stenosis, so if you come to the office and you have carotid blockage but you haven't had any symptoms, fortunately, and I put you on best medical therapy, what we spoke about, antihypertensive, cholesterol, statin, aspirin, Plavix, smoking cessation, etc., the disease is still going to progress. And so it can halt the progression of disease, but this slide shows that over time, even asymptomatic patients who are on the appropriate medical therapy often progress to a more severe blockage. And that's why it's very important that we follow you every 6 months or 3 months or 12 months, whatever the appropriate interval is, depending on how bad the blockage is, with an ultrasound, again, a non-invasive study that is done in 20 minutes in the office, so that we can catch it, that once it meets that threshold of, let's say, 70% in the case of asymptomatic patients, that we can appropriately intervene, and we don't wait until it's too late and you've already had a stroke. So the idea is to intervene before a stroke happens. Once you have a carotid ultrasound, this slide shows some risk factors based on the duplex ultrasound that we can identify based on the flow through the carotid artery and what the plaque looks like. There are what we call plaques that are more vulnerable to breaking off and going into the brain and causing a stroke. And so this slide just describes the juxtaluminal black area and the plaque area and things that we look for on ultrasound that can help predict some plaques are more likely to break off and cause a stroke than others. So this helps predict what we call vulnerable plaques with the carotid ultrasound. It's a good thing to keep in mind that a patient that you see that's had a stroke at one point before the stroke was asymptomatic. So if they've had a stroke from carotid blockage, from carotid stenosis, before that stroke they had carotid stenosis and they were asymptomatic. So the idea is that we want to prevent a stroke. We want to catch the disease early before it's caused a stroke and fix it and remedy the situation and to prevent stroke. And so again, any patient that has no symptoms but has a blockage of 70% or more should have their carotid artery fixed, revascularized. And if you've had a symptom, even if it's a TIA, if it's 50% or more, you should have your carotid artery revascularized. And this is some data from some landmark trials, the NACIT trial, which is a symptomatic trial, and the ACAS trial, which is the asymptomatic trial. And what it shows is what I told you before, which is if you have blockage and you're symptomatic and it's 50% or more, which is the bar graph on the left, the risk of stroke with just medicine is 26% over 5 years versus about 1/5 of that with surgery. And if you have asymptomatic carotid blockage and you're at 70% or more, and actually the ACAS trial was 60% or more, but in practice we use 70%, it's about a 2-fold increased risk of stroke if you're just on medicines than if we either do surgery or a stent. These are some intersocietal guidelines that were published by the American Heart Association, by the Society of Vascular Surgery, on acceptable outcomes of carotid revascularization, so carotid endarterectomy, carotid stenting. For patients with asymptomatic disease, a stroke or death rate of 3% or less, and for symptomatic disease, a stroke or death rate from 6% or less. And so any person that's practicing carotid interventions should meet these baseline standards in terms of outcomes. The purpose, again, of treating carotid artery disease is to prevent a stroke. It's not to trigger a stroke in the process. So if we're doing a procedure to prevent a stroke, we're not going to want to cause a stroke by the actual procedure. So protecting the brain in any procedure that we do, otherwise known as neuroprotection, is critical. And if you look at carotid endarterectomy, which is the surgical treatment where we make an incision in the neck and clean the blockage out, that's about 90% of the procedures that are done nowadays. It's a tried and true method. It's been around for 65 plus years. And how we protect the brain in carotid endarterectomy is that when we make an incision, we actually put a clamp on the carotid artery so that no plaque goes up to the brain while we're cleaning it out, and that side of the brain is being supplied by the other carotid artery. During the surgery, we clean everything out, we sew it back together, and then we take the clamp off. So you don't get much better neuroprotection, protection of the brain, than from a clamp that's closing the artery shut. And because of that, the risk of stroke in carotid endarterectomy is very low. The 30-day risk of stroke is about 2.3% in the most recent CREST trial, which is the level 1 randomized controlled trial, which is really standard state-of-the-art trial nowadays. If you look at carotid stenting through the groin, so transfemoral carotid stenting, where they go up through the groin, put a wire through the aorta and up to the carotid artery, the neuroprotection mechanism protecting the brain is actually a little basket that we put up in the carotid artery, and then we do the ballooning and stenting with a basket in place to catch any debris that might break off and go up into the brain, and then we remove the basket. The problem with that is when you go through the groin, you have to actually navigate a wire and a catheter through your aorta and up into the carotid artery, and then through the carotid artery plaque before you put the basket in. And when you're doing all that manipulation, whether it's in the aorta or in the carotid artery, you can knock off a little piece of plaque, because there's often people that have carotid blockage also have plaque in their aorta as well. You can knock off a little piece of plaque and it can go up into the brain before the basket is deployed. And so most of the strokes that happen with transfemoral carotid stenting happen before the neuroprotection device is placed, before the basket is placed. Right now, transfemoral stenting is about 10% of the procedures. It was started in the 90s, but really popularized in the mid-2000s. 2005 is when the trial came out, the Sapphire trial in the New England Journal of Medicine. When you compare carotid stenting to carotid endarterectomy has a little bit of higher what we call adverse events, because it's a general anesthetic, it's a longer surgery, so the risk of maybe having a heart attack from the surgery or a cranial nerve injury is a little bit higher than if we just do a puncture in the groin and it's minimally invasive and go up and put the stent in. The flip side of it is that the risk of stroke with transfemoral carotid stenting is about twice the risk of stroke with carotid endarterectomy. It's about 4.1% versus 2.3% with carotid endarterectomy. And the reason, as I said, is because most of the strokes will happen before that basket can get up into the carotid artery and protect the brain. So what about TCAR? This is another acronym to add to the alphabet soup that we have in vascular surgery. But TCAR stands for transcarotid artery revascularization. And what that does is it really combines the best of both worlds. It combines the best of carotid endarterectomy in terms of the neuroprotection and the very low risk of stroke, and it provides the best of the minimally invasive treatment that you would get from transfemoral carotid stenting and low adverse events, low myocardial infarction, low nerve injury, etc. So TCAR is a combination of those two things. It's a minimally invasive approach that has the same or better neuroprotection than carotid endarterectomy. This is a little animated video that describes the TCAR procedure. And the beauty of the TCAR procedure is that the stent, instead of being put in through the groin, is put in through the neck. And by putting it in through the neck, we avoid the aortic arch and all that manipulation in the aorta. So we make a little incision just above the clavicle, and we access the carotid artery with a little needle. and then we're able to put a little sheath in and do our carotid stenting procedure from the carotid artery. The beauty of it and the neuroprotection part of the TCAR is that we use what's called flow reversal. So instead of having to put a basket like you do with transfemoral carotid stenting, we hook up the sheath in the neck to a sheath in the femoral vein in the groin, and it actually reverses the flow of blood. So it sucks the flow backwards. Instead of the flow going up to the brain, it sucks the flow backwards, and then it runs it through a filter, and then it returns it through the heart, through the femoral vein. And we can do our ballooning and stenting while the flow is reversed, while it's going backwards. And so any fragments that may break off don't go up to the brain. They get sucked backwards, filtered, caught in the filter, captured in the filter, and then the blood gets returned through the femoral vein back to the heart, so there's no blood loss. That's the real beauty of the TCAR, and it's done through about a 1-inch incision just above the collarbone, so very low and cosmetically is very pleasing. But instead of, again, to compare transfemoral carotid stenting where we have to put a wire through everything, including the blockage, to put a basket, and a lot of times on the way up, I'm putting a basket in, the plaque breaks off and causes a stroke. Here, you have cerebral protection from the beginning. So instead of cross-clamping the carotid artery like you do in an endarterectomy, we're reversing the flow. So before there's any wire put into the carotid artery, nothing is advanced through the plaque until the flow is reversed. So everything is done with reversal of flow. So we're, again, sucking the blood backwards, collecting the fragments that way. And this is just a diagram of the setup, again, connecting the sheath that's in the neck to the sheath that's in the groin, and pulling the blood backwards into the filter. So what is the data with TCAR? There's been a lot of studies that have evaluated TCAR. There's over 25,000 TCAR procedures that have now been done. Again, if you look at the data from the CREST trial, which is our most recent randomized controlled trial, level 1 evidence, the risk of 30-day stroke with transfemoral carotid stenting is about 4%. The risk of 30-day stroke with carotid endarterectomy is about 2%. The risk of 30-day stroke with TCAR in the trials is about 1%. So it's about half that of carotid endarterectomy and 1/4 the risk of stroke if you're going to put a stent in through the groin. Those are actually high-risk patients that are in the TCAR data set and normal risk patients that are in the CREST data set. So despite the fact that the patients that are receiving TCAR are sicker and have many more comorbidities, the results are better. If you actually look at the Society of Vascular Surgery registry data, which is thousands and thousands of patients, that looked at high-risk patients that undergo carotid endarterectomy and high-risk patients that undergo transfemoral carotid stenting, the numbers are even more favorable for TCAR. So again, TCAR is about 1.3, 1.4%. Carotid endarterectomy, when you're high risk, goes to 3.6%, and transfemoral stenting goes to about 5%. So now if you're comparing apples to apples, high-risk patients to high-risk patients, TCAR is even more favorable than both carotid endarterectomy and transfemoral carotid stenting. We published a paper that was published in the Journal of Vascular Surgery that looked at real-world results with carotid endarterectomy in normal risk patients just to validate the results from the CREST trial. And again, our overall stroke rate in that study was about 2.5%, and these are about 4,000 patients in this study, so a very big sample size. And that compares favorably to, or similarly to, the 2.3% found in CREST. And again, these are the studies that have been done at multiple places, multiple clinical trials that all have that same 1% or low 1% stroke rate for TCAR. Again, if you compare TCAR to carotid endarterectomy, to the surgical treatment, there is a less risk of having a heart attack, a myocardial infarction with TCAR, higher risk with carotid endarterectomy. So it's not all about the stroke risk. It's 1% versus 2%, so it's half the stroke risk of endarterectomy, but you also get less risk or less rate of heart attacks, myocardial infarctions, almost no cranial nerve injuries with TCAR, less time in the operating room. Carotid endarterectomy is probably about 2 hours in the operating room. A TCAR is about 30 to 45 minutes. Shorter length of stay in the hospital. You pretty much go home the next morning within 24 hours after a TCAR. And less risk of bleeding and less risk of reintervention. If you look at, so that's TCAR versus endarterectomy. If you look at TCAR versus transfemoral carotid stenting, very important because, again, you have basically two surgical treatments. You have surgery, carotid endarterectomy, or you have stenting. And within the stenting form of treatment, you have carotid stenting through the groin, transfemoral carotid stenting, or carotid stenting through the neck, TCAR. If you compare TCAR versus transfemoral carotid stenting, this is a study, again, out of what's called the VQI, which is the Vascular Quality Initiative, which is the large national database, quality database that we have. It's over 3,000 patients that were matched. And the risk of stroke with TCAR is, again, in that 1.5% range, and with transfemoral carotid stenting was over 3%. It also fared more favorably in terms of 5-year stroke risk. So 5-year stroke risk was half that. TCAR was half that of transfemoral carotid stenting. Less radiation to the patient with TCAR, about 1/3 less than with transfemoral carotid stenting. Less contrast, about 1/3 less contrast given to the patients with TCAR versus transfemoral carotid stenting. So based on this data, TCAR is superior in all ways, not only in stroke and death, but also in terms of other risk factors, exposure to radiation, contrast, time in the procedural time, etc. The proof is really in the filter. This is a slide of all the debris that can be captured in the filter when you do TCAR. So again, you're doing the procedure, you're reversing the flow, and the blood is getting washed through a filter, and the filter is capturing all of these particles. And this is a slide of all the different particles that can otherwise would have gone up to the brain and caused a stroke, but we're capturing it with the flow reversal in the TCAR filter mechanism. If you look at what we call transcranial Doppler, or TCD, and that's a little Doppler that you put on the brain, on the scalp, and it measures the plaque that could break off and go into the brain. So transfemoral carotid stenting, they compared TCAR, CEA, and transfemoral carotid stenting. Transfemoral carotid stenting showed a significantly higher embolization rate, so plaque breaking off and going to the brain, based on transcranial Doppler than CEA or TCAR. Most of the embolizations, again, happen before the filter is being put in. So as the wire is being manipulated through the groin, up through the aorta, and up through the carotid, little pieces of plaque are being knocked off and going up into the brain, and then the transcranial Doppler is capturing those. So much higher rate of embolization to the brain with transfemoral stenting than with TCAR, where you have flow reversal, or with carotid endarterectomy, where you're clamping the artery. And this is another study that looked at that, and this looked at diffusion-weighted MRI of the brain. And it looked at how many little mini strokes based on MRI to the brain did you happen with the 3 procedures. And you can see that with carotid endarterectomy, it's about 17%. TCAR is very similar, 18%. So you're getting the same protection of the brain, the same neuroprotection as clamping the artery with CEA as you do with flow reversal with TCAR. But you can see transfemoral carotid stenting is as high as 87%. So you're talking about 17%, 18% with TCAR and CEA, and up to 87% with transfemoral carotid stenting. Again, if you look at myocardial infarction or other adverse outcomes with carotid endarterectomy, the risk of MI is about 2%. Heart attack is about 2% with carotid endarterectomy. With TCAR is 0.7%. So statistically significant difference. And if you looked at nerve injury with carotid endarterectomy, it's about 5% with carotid endarterectomy. Only about 2% of those are permanent, so it's still a very low risk of nerve injury with carotid endarterectomy. But compared to TCAR, it was 5% versus less than 1%. And in terms of permanent nerve injury, it was 0% with TCAR and 2% with carotid endarterectomy. From a cosmetic standpoint, TCAR is preferred to carotid endarterectomy. Carotid endarterectomy is going to leave a little scar about, 5 inches in the neck, and TCAR is a 1-inch little incision that's low in the neck, right over the collarbone. So cosmetically, TCAR for patients is preferred over endarterectomy. In terms of TCAR, what patients can qualify for TCAR? Right now, TCAR is only indicated for patients that are considered high risk for carotid endarterectomy. There's a long list that's on this slide of physiological high risk and anatomical or surgical high risk for endarterectomy. Age over the age of 75 is one, so any patient over 75 or above is a candidate for TCAR. Patients who have congestive heart failure, who have coronary artery disease, who have had a previous recent heart attack or heart intervention, patients that need vascular surgery, have peripheral artery disease, obviously an abnormal stress test, uncontrolled or poorly controlled diabetes, COPD or lung disease, kidney disease. Those are patients that are all high risk for carotid endarterectomy and would be a good candidate for TCAR. And then there's some anatomical risk, patients that have had neck surgery already or have had radiation to their neck. Doing another incision in a scarred neck can result in an increased risk of nerve injury and wound complications with endarterectomy, so those patients are better off having a TCAR. Patients where the lesion is high, usually above the jawbone, it's hard to get to that surgically with an endarterectomy, so those patients should have a TCAR. Patients that have 100% blockage on one carotid artery and the only carotid artery that's supplying the brain has significant blockage, those patients are at a higher risk of stroke with endarterectomy, and those patients should have TCAR. So there's about 15 or so risk factors for endarterectomy that's included on this slide where those patients would be better off and probably benefit with TCAR. Our TCAR program at Delray Medical Center has performed about 200 cases to date. We performed the first TCAR in South Florida in June of 2018, and since that time have been recognized as a National Center of Excellence for TCAR in all 3 years, 2018, 19, and 20. We are also a national training site for physicians who come and want to learn how to perform TCAR. So in summary, TCAR is a clinically proven less invasive alternative to carotid endarterectomy that provides a lower stroke risk at 1% versus carotid endarterectomy at 2% and transfemoral carotid stenting at 4%, but also has the added benefit of less myocardial infarctions, less cranial nerve injury, less other adverse events, and is more cosmetically pleasing. Patients have a shorter hospital stay, shorter procedure time. It really combines the best of both worlds. You get the minimally invasiveness of the stenting procedure with the neuroprotection of carotid endarterectomy. Thank you very much for your time. I'd be happy to answer any questions.